Hello everyone, welcome to your health assessment lecture. In this lecture, we will be covering the components, purposes, and the types of assessments, how to prepare the patient for an assessment, how to systematically conduct the assessment, the techniques of assessment, and how to document the physical assessment. Let's talk about health assessment. What is a health assessment? A nursing health assessment involves gathering information about the health status of the patient. You gather the data, you synthesize it, you cluster the data, evaluate it, and then based on the data that you've collected, you plan appropriate nursing interventions for that patient. It includes two major parts. It's the health history and the physical assessment. Let's look at the health history. What is the health history? It's basically a collection of data, subjective and objective, that provides information about the patient's health status. These are the components of the health history. You have the biographical data. This is the basic information, the demographics about the patient, the name, address, biologic sex, sexual orientation, gender identity, date of birth, marital status, occupation, race, ethnic origin, religious preference, advance directives, their primary care provider information, cultural background, and their preferred language. Then we have the reason for the visit. We need to know why is the patient here today, how we can help them today, right? So for that, we ask them why they're seeking care. And we want to know in their own words. We want them to describe the reason for seeking care. This will actually help us to focus the rest of the assessment. Then we have the patient's present, health concerns, right? History of present illness, that's what it's called, HPI. So this will include the explanation of the symptoms, onset of the problem, location, duration, how intense is the problem, what is the quality and description of the problem, what helps relieve it, what are any associated factors, did you have any past occurrences of this problem, have you had any treatments for it, how the problem was affected, how the problem has affected the patient. So these are important things that you want to know about the HPI. Then we have the medical history. We want to know what is their past medical history, right? Any childhood or adult illnesses, chronic health problems, like do they have diabetes or hypertension? We want to know if they had any previous surgeries, if they had any accidents or injuries or surgeries. We want to know if they're up to date with their immunizations. We want to know if they're up to date with their screenings, for example, the mammograms, their colorectal tests. We want to know if they take any prescribed over-the-counter or prescription medications, including vitamins, supplements, or any other home or herbal remedies. We basically do a medication reconciliation. We collect all that information from the patient. Then we want to know their family history. Any history of any contact with family members with communicable diseases or environmental hazards. If somebody in the house had a flu and maybe that's why they're sick and they came to seek treatment. This is very important for us to know. Then we want to know their functional history. For example, how they function psychologically, their psychosocial factors and lifestyle and health practices. Their level of activity, for example, how they exercise, were there any recent changes in their life, for example, a death of a loved one. We want to know all of that. Then we will do what we call a review of systems. This is a physical exam of all body systems, in a very systematic manner, and it's part of the nursing assessment. So this includes environments in which people live in. Excuse me, sorry. Social support. Do they have any support in their family, in their neighborhood? Socio-cultural factors, language barriers, literacy. What is their health literacy? What level is it? Access to food, healthy food. Access to transportation, job opportunities. I mean, do they work still? Do they not work? Stable housing. Do they have a safe environment to live in? How is their ability to perform their activities of daily living? And their instrumental activities of daily living, these both are slightly different. So ADLs are basically activities such as eating, bathing, dressing, toileting. Instrumental activities of daily living are activities that are needed to qualify a person to live independently. For example, are they able to take care of their house? Are they able to prepare their meals? Are they able to manage their finances? And are they able to, provide transport to themselves, like drive to places, drive to their appointments, drive to the grocery store? What are their values, beliefs, and spiritual resources? Any use of alcohol, illicit drugs, or tobacco? What environmental exposures or occupational hazards do they have? Intimate partner and family care, domestic violence situations. How is their mental health? How is their sexual health? Their sexual history, their sexual activity, gender identity, and sexual orientation. I know sometimes these questions might feel a little uncomfortable, but these are crucial conversations that we need to have with our patients. So let's move on to data. So we want to know everything relevant about the patient so we can provide proper care to them. Right? Now, data that we collect is divided into two types. You have subjective and you have objective. Subjective data is the patient's experiences, perceptions. They're only known by the patient and are reported by the patient. Right? So we use the patient's own words, sensations, symptoms, perceptions, desires, preferences, beliefs, ideas, values, and personal information. And remember, this is all in the patient's own words. So this is subjective to the patient. An example would include the patient's report of pain and nausea. The patient might tell you, oh, I'm always in pain, my lower back hurts. And then you can, gather objective data regarding that pain and say, okay, can you rate your pain out of a scale of 0 to 10? And if the patient says it's, say, a 5, and now you've quantified that data, right? But before you quantify it, it's still subjective data. Then we have objective data. This is measurable data. It has to be measured, right? It's objective. It's directly observed through inspection, percussion, palpation, and auscultation. You use your assessment techniques, these 4 assessment techniques, to gather this data. Then you have elicited through general observations and physical exam. You do your physical exam from head to toe. You gather their height, weight, appearance, BMI, lab results, their physical assessment. All of this gives you objective data. It's obtained through the patient's health record, right? You look in the patient's health record, their past medical history that they've been diagnosed with, the medications they take that were prescribed or over the counter. All of this is objective data. Then we have observations reported by the patient's family, which is their significant others, their children, their caregivers, about the patient. This is also included in objective data because it's not in the patient's own words. So an example of that would be vital signs, height, weight, appearance that you notice in the patient, behavior that you notice, and you have lab results, for example. These are all part of objective data. Now, some considerations when collecting the health history. The source of the information is also recorded. If, say, the patient's wife said something about the patient or their symptoms, then you will record it as the patient's wife stated. So the source of the information should always be there. The differences in language and culture may have an effect on the quality and safety of healthcare. We want to make sure that they understand the information and make informed decisions. Always ask open-ended questions. Avoid, paraphrasing for them and interpreting what they're trying to say. Always ask open-ended questions. Let them answer the question. Let them provide a description. Explore the symptoms thoroughly. Family history provides insight into disease conditions which an individual or patient may be at risk for. Now, sometimes you ask a patient, and hey, do you have these headaches, for example, or the lower back pain that we mentioned all the time? They might say, no, not all the time. It's only maybe once in a month or so. But the wife might say, you complain every morning about this back pain, right? So you learn information about the patient's symptoms through the family, and it's very important to include the family in care. Functional health. Why do we need to know their functional health? Because it helps to identify the effects of health or illness on the patient's self-care abilities, right? How is it impacting their daily life? It's always important to be non-judgmental. Explain why you need that information. Some information that you need might be uncomfortable for the patient, but explain to them why you need it. Right? Develop a trusting relationship. That's very important. Ask the patient about their level of activity and exercise, sleep and rest and nutrition. Talk to them about that, and ask them open-ended questions. Assess the patient's ability to perform ADLs. There's a tool called the CATS Index of Independence of ADLs. It's a tool that is used to measure how they bathe, how they dress, how well they, toilet, transfer, their continence, their feeding status, all of that. Then we have mental health. Be very non-judgmental and ask them questions in a very inclusive way without being judgmental. This is a great video about how to collect a health history. This is posted in your Canvas course. Please take a few minutes and listen to how this lady asks the patient about his symptoms. Now, going back, that was the health history. Now let's look at physical assessment. What is physical assessment? It's basically a collection of objective data. Remember, subjective data is the patient's own words. Objective data is the information about changes in the patient's body systems, and it should be done in a very systematic way. Before we even jump into physical assessment, let's talk about the types of physical assessments. There are 4 types. You have the comprehensive assessment. Comprehensive assessment is broad, and it includes a complete health history and physical assessment, head to toe, for that patient. This is usually done when a patient gets admitted to the facility and you need to create a baseline for that patient. Then we have the ongoing partial assessment. This is a follow-up. It's conducted at regular intervals throughout the day. It concentrates on identified health problems just to monitor their changes. For example, if the patient had a headache, you administered pain medication, you want to follow up and see how is their pain now, or to detect any new problems. Then we have focused assessment, to assess a specific health issue, 1 or 2 body systems. It's smaller in scope than a comprehensive assessment. And the other one is emergency assessment. It's a rapid, focused assessment conducted when addressing a life-threatening or unstable situation. For example, a long-term care resident who begins choking in the dining room. When this happens, you're not going to say, okay, let me do a head-to-toe assessment, check everything in them and start asking them questions. No, they're choking, so you need to take care of that first. So this is called an emergency assessment. A bleeding patient, or an unresponsive patient in the rehab unit, a factory worker threatening violence. So these are emergency situations, and then you need to do an emergency assessment. It's very important for a nurse to be organized when we're doing this and assess quickly and efficiently based on the patient's priorities. A partial health assessment should be done on all assigned patients within the first hour of the nursing shift. So this is your health assessment that you need to do in the beginning of your nursing shift. Focus assessments are done when the clients complain of a specific issue, such as patient says they have abdominal pain. Then you'll do a focus assessment to, listen to their bowel sounds, inspect their abdomen, palpate it for pain. So you do that, and that is called a focused assessment. Now, let's talk about the steps of a physical assessment. So there are 3 steps. First, you have to prepare the patient and the environment for the physical assessment. Then we're going to talk about the techniques of physical assessment. And then we will move on to the 3rd step, which is conducting an actual physical assessment. Preparing for the physical assessment. You gather your supplies, get all the equipment you need for your physical assessment. For example, your watch to count their their heart rate. Then you want thermometer. Then you want your blood pressure, sphygmomanometer. Sorry, I can never pronounce that. You need a scale to check their weight. Flashlight or pen light, stethoscope, tape measure, eye chart. So these are all the important tools that you need, your nursing tools that you need to perform the assessment. So this is part of your preparation. Positioning the patient. This is very important. When depending on the type of assessment you're doing, that's how you will position the patient. Of course, first you have standing, right? Standing erect. To assess posture, balance, gait, you want to see, can they stand straight? But don't use this for patients who are very weak or who feel dizzy because they might fall. The next position is the dorsal recumbent. The patient lies on the back with the legs separated, knees flexed, and soles of the feet on the bed. This is used to assess the head, neck, anterior, thorax, lungs, heart, breast, extremities, and peripheral pulses. It should not be used for abdominal assessment because it causes contraction of the abdominal muscles because of the legs stretched out. Then we have the prone position, where the patient lays on their flat on the abdomen with their head turned to one side. This is usually used to assess the hip joint and the posterior part of the thorax. Sitting position. This is when the patient is sitting in the chair on the side of the bed or examining table. They remain in bed with the head elevated, allows for visualization of the upper body. It facilitates lung expansion. When they're sitting, the lungs expand. And it's used to assess vital signs, to assess the head, the neck, the anterior, posterior thorax, your lungs, your heart, breast, upper extremities. This is the perfect position to put the patient in when you want to listen to their lung sounds and their heart sounds. Then we have supine, where the patient lays flat on their back with the legs and knees, legs extended and knees flexed. This is used to assess sometimes vital signs. When the patient is in a hospital, they're in bed, we assess their vital signs while they're laying down. Then it's also good to assess their head, neck, and their anterior thorax, lungs, heart, breast, abdomen, extremities, and peripheral pulses. This is the preference for when you want to listen to their abdominal sounds. Inspect the abdomen, auscultate it, and palpate it. Then we have other positions. We usually don't use the leihotomy position or the knee chest position. This is mainly used, in other specialties. But we have the Sims position, either side with the lower arm below the body and the upper arm flexed at the shoulder and elbow. Both knees are flexed with the upper leg more acutely flexed. It is used to assess the rectum or the vagina. Now, sometimes this is the position we use to, administer an enema. So it's good to remember the position. It's called the Sims position. So in preparation for the assessment, we talked about gathering equipment, how to position the patient. The next thing we're going to talk about is draping, is providing privacy. You're going to keep the patient warm during the assessment. Drapes may be paper, cloth, or just bed linens, a blanket. During the assessment, it's very important to expose only the parts of the body that are being assessed to maintain the patient's modesty and comfort. Don't, avoid going in the room and taking off all their their gown and the blankets, everything, and they're laying there naked, and you're saying, okay, I'm going to do a physical assessment now. That takes away their dignity and their modesty. You know, they're already going through a lot, so the least we can do is protect their privacy and give them that dignity. So these are the first two steps of the preparation and the techniques used for assessment. Now let's move on to conducting a physical assessment. Now, in your next lecture, we are going to cover the head-to-toe assessment, and the next video will cover the head-to-toe assessment. On this sheet, I just want to talk a little bit about the general survey, which we're going to be covering. What is the general survey? This is the information obtained from the general survey provides clues to the patient's overall health. It gives you a broad picture of the patient. So you have their health history, you measure their vital signs, you measure their head circumference. That's why you're going to need the tape. You use the tape and you measure the head circumference in centimeters. This is mainly done for pediatric patients. Then we have their height and weight. We want to collect their BMI. We want to make sure that they're in a healthy BMI category based on their height and weight. Then we have their nutritional status. We want to know, are they suffering from malnutrition? How do they eat? What are their eating patterns? Are they at risk for any diseases? We also want to use accurate scales and measuring devices if the patient cannot stand erect, right? You can use the bed scale or a chair scale. And appearance and behavior. This is extremely important for us to observe. The nutritional status, what is their body built like? What is their posture, their gait, their proportion of height and weight? Neurological problems. Observe for erect and slumped posture, movement, gait pattern, uncoordinated spontaneous movements, like people who have Parkinson's disease have. Observe those things. Then you have illness of distress, changes in posture, skin color, respirations, nonverbal communication, the grimacing, those are nonverbal symptoms. Then we have hygiene and grooming. Observe cleanliness of the body odors, note any deficits. Neurologic problems, assess their cognitive processes. How do they speak? How are their speech patterns? Are they oriented to person, place, time, and situation? That's an extremely important component of the health assessment, to know, are they oriented? Are they alert and oriented to which means person, place, time, and situation. Mood and mental health. Observe their speech, facial expressions, ability to relax, eye contact, their behavior. Are they anxious? Are they depressed? These are all extremely important things that we need to observe in the patient. So that is the first part of the physical assessment. The next lecture will be on the head-to-toe assessment, and we will go systematically from head to toe. And I will see you in lecture.